John Williamson was a country GP in far north Queensland before becoming a specialist in anaesthesia and intensive care. As a specialist, he became involved with colleagues from many disciplines in the area of marine envenomation, and he's been responsible for the definitive textbook on the subject, Venomous and Poisonous Marine Creatures. An interest in hyperbaric medicine led to a career change and a move to Adelaide. In Adelaide, he became an associate professor and the director of the Diving and Hyperbaric Medicine Unit. He made important contributions to the Australian Patient Safety Foundation and to the Anaesthesia Incident Monitoring Service. He's been a member of the RAAF Reserves, Deputy Director of Training at St John's, and has held an open water scuba diving instructor certificate. Now, with many awards to his name, he is retired and living in Melbourne, where he acts as a guide at both the Shrine of Remembrance and at the Geoffrey Kaye Museum of Anaesthetic History. Welcome to the College of Anaesthetists, and thank you very much, John, for coming to talk to us today.
And thank you for having me, Chris.
So how did you become interested in marine envenomation?
Well, going to Townsville, as a resident, I became acutely aware that surf life saving was in real trouble in northern Queensland and northern Australia. But of course I went off onto my general practitioner duties, and when I came back as an anaesthetist, it was still a big problem. In fact, it looked like surf life saving in northern Australia would die, because there were people dying and being severely stung and certainly having their day spoiled on the beaches from what was then a multi-tentacle box jellyfish known as Chironex fleckeri.
So a lot changed around that time, I think, with resuscitation on the beach. Were you involved with surf life saving and the protocols for that resuscitation?
Very closely in a medical sense, and happily not too long after I came to Townsville, 3 or 4 years, Associate Professor Vic Callanan, as he is now, came, and he was a properly trained intensivist. He got involved quickly. That led to the most amazing combination of cross-discipline work with a team of people. And it was just amazing to see. At this time, the great authority on all this subject was Dr. Jack Barnes in Cairns. Mm-hmm. Jack was a general practitioner, but at the same time a very acute mind, and they both knew of this problem of the multi-tentacle box jellyfish. And Jack set up a little laboratory under his own house, looking down microscopes and looking at the tentacles, and he demonstrated to his satisfaction at the time that methylated spirits would reverse the action of the unfired stinging cells called nematocysts in the tentacles. So it was a multidisciplinary combination, and very quickly Vic and I realised that these other expert people in their field could solve problems we just didn't know how to deal with. So it was a wonderful thing, and I think perhaps medicine should do this more often.
Yes, the team-based approach to things.
Yes.
So let's just wind back a bit. The methylated spirits was problematic, I believe, for several reasons. Firstly, it's flammable.
Exactly.
And it also caused some other problems with some of the patients.
Well, Vic and I treated a really major sting on the beach right at Townsville. And because it was close to the Townsville General Hospital, she reached the hospital in the very acute phase of her massive sting. She happened to be a heavily pregnant woman too. And we treated this woman essentially as resuscitation, and we flooded the stings with metho, but it was necessary to intubate her and ventilate her because she had pulmonary edema and she was semi-conscious. She sort of stabilised over the night, and the next morning we reviewed her, and it was obvious from the blood gas measurements that we could extubate her. So we extubated her and checked her over and thought she was coming good, went away, and we got a call from the senior nurse in the intensive care unit. And she said, "You better come and look at this young lady." Now, we came back, and she wasn't cognitively functioning normally. In fact, in the words of the senior nurse, she is off her head. Mm-hmm. And when the nurse said that, Vic and I looked at each other, and we just wondered, and we took a blood sample, and she was drunk.
From the methylated spirits.
Yes. She'd absorbed it through the damaged skin and also the fumes.
Just amazing.
Yes,
really.
it is. So to our great relief, it wasn't brain damage.
And to your great relief, she then delivered a normal baby.
She did indeed, and the baby was perfectly healthy. And incidentally, she only survived by resuscitation on the beach, where she was stung by a nurse in the nearby caravan park who was also advanced pregnancy.
And methylated spirits was replaced ultimately by vinegar. Do you want to tell us about how that came about?
It's an amazing story, due again to the great thinking of Dr. Bob Hardwick. Around this time, it was argued that the multi-tentacle box jellyfish would come in from the open ocean. No one knew the life cycle. Mm-hmm. And Bob, again, in the face of some sort of cynical remarks from his colleagues, worked out exactly the life cycle of Coronex flickeri, the chirodrobid multi-tentacle box jellyfish, and that was the first time in the world that had ever been done, not just Australia. And he showed that they were a bit like salmon. So once Bob had sorted that out, he began looking very carefully at the tentacles of these animals in his laboratory at James Cook University. And he, of course, had fresh tentacles, and he proceeded down the microscope to examine them one day, and by sheer accident, he put methylated spirits on a fresh piece of Coronex tentacle without meaning to do so. And it produced massive nematocyst discharge. So he proceeded to search for an alternative, systematically using mono and dicarboxylic acids to start with, and to everyone's enormous relief, he found that acetic acid in water, 2 to 10% acetic acid in water, produced immediate ghosting and inhibition of the nematocysts. 4 to 6% acetic acid in water is vinegar. It has an infinite shelf life, it's non-flammable and reasonably non-toxic. So the switchover was a fairly anxious period, but gradually Surf Lifesaving took to it, and the publications in the Medical Journal of Australia, I think, were the main authority on which this was based, and now that's used everywhere.
So there were some quite interesting people that involved in catching the jellyfish.
Most amazing people, and when I mentioned this close liaison with senior surf lifesavers, that included these people, with the exception of one remarkable man, Charles Fitzpatrick. And Charles Fitzpatrick was an elderly retired railway worker in Townsville, and he became one of the most expert catchers of the Coronex animals without getting stung himself and without damaging the animal. And Ron Southcott sent him detailed instructions about how to preserve these animals using formalin and dispatching them to the South Australian Museum. And he did that for years, working with Ron, who was in Adelaide, and the South Australian Museum has the biggest collection in the world of magnificent specimens of Coronex flickeri.
Amazing. So it's not just the box jellyfish that's a problem. There's another tiny little jellyfish which has been quite a problem in Australia. It remains a problem. Jack Barnes was very involved in the discovery of the Irukandji jellyfish, I believe, as well.
Jack suspected for a long time that this was a tiny animal because no one ever saw it. So what's Jack do? He puts on scuba gear and he goes and sits in seawater about 6 feet over his head on a clear sunlit day in North Queensland in summer, and just waited looking at the surface. And sure enough, a small shoal of these tiny jellyfish eventually, I don't know how long he had to wait and how many times he had to do it, but he did it. And he captured one of these animals. He may have had more than one actually, without damaging it unduly. And then he proceeded to sting himself and a good surf life-saving mate and his son with these animals, and all three of them got an Irukandji syndrome. Now, ethics committees didn't exist, and this was potentially dangerous without Jack realising it. Now, these were fit and healthy young people, but that absolutely verified the cause of the Irukandji syndrome for the first time in the world.
The other thing that we didn't talk about before was the antivenom for the jellyfish, which was another story which you were involved in. I guess catching these jellyfish was part of that story too.
This brings in Storm Sutherland. What a wonderful man he was. I mean, he was a tremendous support and a great authority and one of the world pioneers in marine antivenom production. Of course, the funnel web spider antivenom was entirely his work anyway. My wife and I are sitting on a beach in Townsville, This would be in the 80s, and a young lady in a bikini from Canberra walked into the water and then screamed and jumped backwards. We got her to the emergency department, and I got up a line and I gave intravenous Antivenom that Strawn had supplied, and we had some at the Townsville General Hospital at this stage. She was writhing, and in a circulation time after I gave it, slowly, just the first ampule, she stopped writhing. And I watched this thing, and in front of my eyes, the acute, intense inflammatory reaction started to fade. In front of my eyes. So I was halfway through the second ampule, and she sat up. She said, "Oh, that's better, Doc."
Amazing.
Because we know clinically that the duration of the toxic effect of this venom is reasonably short-lived. If you get busy with resuscitation, there's every chance that the myocardium, if it's not coping, will kick off again.
Now, back to you. Your involvement in all of this also got you involved in hyperbaric medicine in Townsville?
Indirectly. I always loved scuba diving, and now in those days, the nearest chamber was Sydney. As it happens, the federal government created what was called the Australian Institute of Marine Science, which is still very much one of the leading centres in the world for marine research, and that's only about half an hour south of Townsville. And they had a chamber. So, talking with the director at the time, we ended up coordinating the hospital at the Townsville General Hospital with the ability to treat patients in this chamber down at Ames. So it involved a trip in a van down and back. And eventually we got the Ames chamber into the Townsville General Hospital.
And it was hyperbaric medicine that ultimately saw you move to South Australia?
I was the director of the diving and hyperbaric medicine unit there, along with, for the first couple of years, it's half-time anaesthesia. But the hyperbaric unit became so busy, it became impractical for me to be going to theatre, half the time. So I became full-time director after about 5 years there, and that was a 20-year appointment. And of course we started to investigate and attempt to treat other conditions than dysbaric illness. We had a couple of gas gangrenes, more than a couple actually. We had a little epidemic of necrotizing fasciomyositis, and we got very seriously interested in treating radiation necrosis of the mandible particularly, which is a horrible disease. I'd get patients referred for hyperbaric treatment by a colleague, a surgeon or someone else, and there'd be no indication whatever for the condition that they've submitted. And when it was something that we thought we could help with, they had this idea that they stopped all the other treatment and we just gave them hyperbaric.
Okay.
Now, you've got to keep everything else going, full bore.
Yeah.
Diabetes control, stop them smoking, social working, microbiology assistance, intensive care where it's necessary. And this was the era of carbon monoxide poisoning.
What about retrieval medicine? You did get involved in that as well, didn't you?
Well, in the diving sense, you see, there'd be people come and they'd go out on boats and they'd get bent or perhaps get embolism, less commonly, but nevertheless it was more common than most people appreciated, that cerebral arterial gas embolism from rapid ascents, uncontrolled ascents. It was necessary to go out. We had a beechcraft which could accept a portable chamber, a Drager Duocom, it's called. That was what we were using then, the German name Drager. And we could actually land closer to that, or if we were in a Bell helicopter, which also could carry the Drager Duocom, we could be winched down. And that patient could then be winched up and put under pressure very quickly and been flown back. And sometimes the aircraft would have to fly for a couple of hours to get back. So you'd have started recompression sooner, and as you can appreciate, the sooner you recompress, the better the outcome. So decompression illness and gas embolism to some extent was managed that way. It wasn't a desperately frequent event, but I suppose I personally would have done certainly half a dozen of those sort of retrievals.
I guess your willingness to get into these helicopters is partly explained by the fact that you have been in the RAAF.
15 years in the Air Force. And. We did a couple of studies. When I was at Garbutt, the Black Hawk helicopter came along. And at that stage we were still using the Iroquois, the one used in Vietnam. And I attended a Army Air Force meeting at Oakey in southern Queensland. It's still the Army Air Force Base, I think. And a very senior person and another anaesthetist in the Colonel's uniform, in the course of the talk, said, everyone knows you can't resuscitate anybody in an Iroquois. And I was sitting next to my very great mate, who was also in the Army, and he was a GP in Oakey. He was my best man, actually. And we looked at each other and we thought, this isn't right. Mm-hmm. So we did a study in Garbutt in Townsville, and I had to train up the blokes in resuscitation skills. And then we did a simulated forward area retrieval and resuscitation in the Iroquois, which was in flight and undergoing evasive flight, being shot at, because it's a forward area. But we found a couple of limitations. We could resuscitate all right, but we couldn't intubate, because you didn't have enough room on the platform of the Iroquois to get above the patient. Mm-hmm. When I went to Adelaide, we repeated this in the Black Hawk. But the Black Hawk was just another story. Much more powerful and with a huge platform by comparison. So we could intubate with the greatest of ease, you know. And again, evasive flight, except I had no idea how evasive a Black Hawk can fly. So we were strapped in with harness, but the centrifugal force just pinned us to the platform. So there was no way we could fall out.
St John's been another part of your career as well, hasn't it? We haven't talked about.
Well, Professor John Pern's responsible for that. So he sort of sweet-talked me into becoming Deputy Director and Chairman of the Technical Advisory Committee, which to some extent suited an anaesthetist. And of course, training of St John Ambulance people is not dissimilar from any other paramedical training.
Mm. John, it's been so interesting talking to you today. Thank you so much for coming.
It's been a great privilege. Thank you for having me, Chris.